tubular maximum, and renal threshold. All chemicals that are actively reabsorbed attach to plasma membrane transporters, which push them against a concentration gradient across the membrane. Each carrier has a specific range of materials it can move. There is a maximum amount of a specific chemical that may be actively transported from the tubular fluid in a given time period, which is only a finite number for each carrier type. When all of the carriers designed specifically for a given substrate are fully utilized or saturated, they are unable to accommodate any more. The maximum reabsorption rate is then attained. The tubular maximum is the rate of maximum reabsorption. Any material that is filtered past the tubular maximum is not reabsorbed, but instead escapes into the urine. All actively reabsorbed substances, aside from sodium, have a tubular limit. Before it achieves its maximum transport capacity, the glucose carrier mechanism has the capacity to actively reabsorb up to 375 milligrams of glucose per minute. The 125 milligrams of glucose filtered per minute at a normal plasma glucose concentration of 100 milligrams per 100 milliliters can easily be reabsorbed by the glucose carrier mechanism because the filtered load is far below the tubular maximum for glucose. Normally, there is no glucose found in the urine. The tubular maximum is not reached until the filtered load of glucose exceeds the 375 milligrams per minute. When the tubular maximum is exceeded, there is more glucose filtered per minute than can be reabsorbed. The maximum quantity is reabsorbed and the remaining glucose remains in the filtrate to be expelled. Therefore, before the amount filtered exceeds 375 milligrams per minute and glucose begins to leak into the urine, the plasma glucose concentration must be greater than 300 milligrams per 100 milliliters, which is more than 3 times normal. Renal threshold is the plasma concentration at which a specific drug, perhaps, reaches its maximum tubular maximum and first manifests itself in the urine. The renal glucose threshold is 300 milligrams per 100 milliliters at an average tubular maximum of 375 milligrams per minute and a GFR of 125 milliliters per minute. Any additional increases in the filtered load causes a directly proportionate rise in the amount of the substance expelled, which we see in the picture. And reabsorption remains constant at its highest rate beyond the tubular maximum. For instance, the filtered load of glucose is 500 milligrams per minute at a plasma glucose concentrate of 400 milligrams per 100 milliliters, of which 375 milligrams per minute can be reabsorbed. The rest would show up in the urine. The study that follows demonstrates a substantial decrease in unfavorable heart failure outcomes by enhancing renal and cardiovascular function, validating the current clinical position. The kidney plays a part in regulating the blood's glucose levels by acting as a metabolic substrate for glucose as well as an organ for gluconeogenesis. The sodium-glucose cotransporters, sodium glucose cotransporter 1 and 2, are located on the brush border membrane of the early proximal tubule. The immune detection of their expression in the tubularized Bowman capsule, and they are responsible for the kidney's ability to reabsorb filtered glucose. The renal maximal glucose reabsorption capacity and the threshold for glucose transit into the urine are higher in patients with diabetes mellitus and contribute to the hyperglycemic condition. Patients with diabetes mellitus who are given the SGLT2 inhibitors, or the sodium glucose cotransporter inhibitors, have improved sodium and glucose excretion, which lowers the glycosuria threshold and increases the tubular maximum transport for glucose. Overall, inhibiting this cotransporter 2 lowers plasma glucose levels while enhancing insulin secretion sensitivity. Because cotransporter 2 inhibits and the reduction of the renal glucose reabsorption and blood pressure is influenced, the hemodynamic profile is improved and tubule glomerular feedback is improved. Their benefits extend beyond glycemic control. With the restoration of the adenosine synthesis and the inhibition of renin-angiotensin and aldosterone activation, this action helps to restore the dense macula responses equilibrium. To maintain glucose homeostasis, the kidneys play the crucial function. This is closely related to the sodium homeostasis, which is controlled by the tubule glomerular feedback and the neuroendocrine system, in addition to being more directly influenced by the renal circulatory balance. The constant detection of sodium chloride in the urine keeps this process operating and enables fine-tuning of the filtration rate without the need for external regulation. The cotransporters 1 and 2 offer extremely effective glucose reabsorption along with sodium reuptake in the proximal portion of the tubular nephron. The tubule glomerular feedback, which is directly impacted by the reabsorption mechanism and has an effect on the intraglomerular pressure, directly changes the salt content of urine. The extremely high glucose and salt absorption that characterizes diabetes, as well as other clinical situations including heart failure, with reduced and preserved ejection fractions, is targeted by the cotransporter 2 inhibition. It has been demonstrated that the enhanced intrarenal control of nephron perfusion reduces unfavorable outcomes linked to circulatory congestion, such as heart failure aggravation. The cotransporter 2 inhibitors provided impressive benefits to patients with and without diabetes who have heart failure.